the findings of a randomized phase 3 study comparing trastuzumab deruxtecan with a treatment of physician's choice in HER2-low, unresectable, or metastatic breast cancer. I'd like to invite Dr. Shanu Modi, a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, to present the results.
Thank you. I echo the other speakers and the opportunity to present our data. I am presenting on behalf of my co-investigators from the DESTINY-Breast04 trial. It's a global study. And it's an honor to present the first results from the randomized phase 3 trial of trastuzumab deruxtecan, which is a HER2 antibody drug conjugate, versus the treatment of physician's choice in patients with HER2-low metastatic breast cancer. So we currently define the HER2 status of breast cancers in a binary model, where HER2-positive breast cancers driven by the oncogene are treatable with currently available HER2-targeted therapies. HER2-negative breast cancers are not. However, within the HER2 population, there are tumors that have low levels of HER2 expression, which we have termed HER2-low breast cancer, for which this HER2 receptor may still be targetable. Our currently available therapies, however, or HER2-targeted therapies, have not proven effective for patients in this subgroup. We currently treat these HER2-low breast cancer patients as HER2-negative breast cancer, where therapy is really guided by hormone receptor status. And ultimately, once we've exhausted endocrine therapies and the few lines of targeted agents, we really have limited late-line options for these patients, most commonly offering palliative single-agent chemotherapy, and this has very modest activity, so we really have a big unmet need for more effective therapies. So trastuzumab deruxtecan, called TDXD, is a next-generation HER2-targeted antibody drug conjugate, and by virtue of its unique properties and mechanism of action, in particular the bystander effect, it has activity across a broad range of HER2 expression in tumors. And in our own proof of principle phase 1 trial, we've previously reported promising efficacy for TDXD in patients with heavily pretreated HER2-low breast cancer. So this really set the stage for the DESTINY-Breast04 trial, which is the first randomized phase 3 study of trastuzumab deruxtecan in patients with HER2-low metastatic breast cancer. This was an open-label, multi-center, multi-nation trial. We enrolled patients with centrally confirmed HER2-low breast cancer who had previously received 1 or 2 lines of chemotherapy in the metastatic setting. In addition, patients with hormone-positive breast cancer were required to have endocrine refractory disease. We defined HER2-low by IHC scores of 1+ or 2+ without gene amplification using the ASCO CAP guidelines. Randomization was 2-to-1, and TDXD was given at the approved dose. The physician's choice of chemotherapy options included capecitabine, eribulin, gemcitabine, paclitaxel, and nab-paclitaxel, and they were administered per the local label. I should go back for 1 sec. The primary endpoint of DESTINY-Breast01 was progression-free survival in the patients with hormone-positive HER2-low breast cancer. Key secondary endpoints were progression-free survival for all patients and overall survival for the hormone receptor-positive patients and all patients on the study. We plan to enroll 540 patients, approximately 480 hormone-positive patients, and 60 hormone receptor-negative patients to reflect the natural prevalence of these receptor subtypes seen in the HER2-low population. And now here are the results. So starting with progression-free survival, I'm showing you here the PFS curves for the entire study population. The PFS hazard ratio was 0.5 with a p-value less than 0.0001. This translates to an improvement in median progression-free survival from 5.1 months with chemotherapy to 9.9 months with TDXD. These results were similar to the findings for the hormone receptor positive cohort and also the exploratory hormone receptor negative cohort. Overall survival was a key secondary endpoint, and these are the curves again for the entire study population. The OS hazard ratio is 0.64 with a significant p-value of 0.001. The median overall survival improved from 16.8 months with standard chemotherapy to 23.4 months with TDXD, which is a 6.6-month gain in survival. To summarize, DESTINY-Breast04 met its primary and secondary endpoints. T-DXd is the first HER2-targeted therapy to demonstrate statistically significant and clinically meaningful improvements in progression-free survival and overall survival compared to standard chemotherapy for patients with HER2-low metastatic breast cancer. The benefits of T-DXd were seen across subgroups, including the hormone receptor positive and negative patients and the IHC 1+ and 2+ breast cancers. I will present more data about toxicity at the full meeting, but we know, or we acknowledge, that lung toxicity is an important toxicity of T-DXd. In the DESTINY-Breast04 trial, we saw lung toxicity in 12% of patients, including a 0.8% incidence of grade 5 events with 3 reported deaths, highlighting the importance of awareness and close monitoring of patients to prevent the serious toxicity. The safety profile of T-DXd in general was consistent with what we have seen in other trials. Overall, these results establish HER2-low metastatic breast cancer is a targetable population of breast cancer with Trastuzumab deruxtecan as a new standard of care in this setting. Thank you.
Thank you. Thank you, Dr. Modi. I'd now like to invite our ASCO expert, content expert, Dr. Jane Meisel, to provide a few additional comments on this study.
Sure. No, what an exciting study to be able to comment on, and congratulations on this amazing work. You know, I think the results of this trial clearly will be practice-changing. As breast oncologists, we've seen Trastuzumab deruxtecan rapidly incorporated now as early as second line for patients traditionally defined as HER2 positive. And everyone who's used it in our clinic undoubtedly has seen some patients, even with significant burdens of disease, have their cancer melt away with this agent. And I think what this trial does is really extend the benefits of this agent to a whole new group of patients that traditionally is really quite difficult to treat. Our endocrine refractory, ER-positive patients, triple-negative patients who have progressed on 1 or 2 lines of therapy, and our HER2-low. Now they can potentially benefit from this drug, which we've seen improves both progression-free and overall survival in clinically and statistically meaningful ways. So I think this will offer a wonderful new option for patients, and also will really fundamentally change the way we think about HER2 status and how we classify this in our metastatic patients. So this is really just a huge win for our patients and for the oncology community.
Absolutely. Congratulations on the study. We're going to have to change the way we report pathology for breast cancer.